Question 1. Which of the following factors plays a significant role in the pathophysiology of type 2 diabetes, contributing to both insulin resistance and impaired insulin secretion? A. Increased release of cortisol. B. Dysfunctional beta cell response to glucose. C. Enhanced insulin receptor sensitivity. D. Excessive insulin production by the pancreas. Answer: B. Dysfunctional beta cell response to glucose. Explanation: Type 2 diabetes (TD) is primarily characterized by two pathophysiological mechanisms: insulin resistance and impaired insulin secretion. Insulin resistance occurs when cells in muscle, fat, and the liver no longer respond effectively to insulin. However, a key factor in the development of TD is the dysfunction of pancreatic beta cells, which impairs their ability to produce and secrete insulin in response to blood glucose levels. Over time, this leads to higher blood glucose levels as the body struggles to compensate for reduced insulin output. Options of increased release of cortisol. Cortisol, a stress hormone, can indeed affect blood glucose regulation, but it does not directly contribute to the core pathophysiological processes in TD as insulin resistance or beta cell dysfunction. Option C, enhanced insulin receptor sensitivity. This would actually counteract the development of insulin resistance, not contribute to it. In fact, people with TD have diminished insulin receptor sensitivity. Option D, excessive insulin production by the pancreas. This occurs in the early stages of TD when beta cells initially try to compensate for insulin resistance, but over time, beta cell dysfunction leads to insufficient insulin production. Question 2. Mrs. Lopez, a 45-year-old woman diagnosed with type 2 diabetes, has been following her prescribed treatment regimen for several months. Despite adhering to her medication and diet plan, her HbAC has remained at 8.5%. After a review of her lifestyle, it appears she has been increasingly sedentary and consuming higher carbohydrate meals than recommended. Considering the situation, which of the following strategies would be most effective in addressing Mrs. Lopez's diabetes management? A. Adjust her medication regimen to include additional oral agents. B. Emphasize more frequent blood glucose monitoring and insulin therapy. C. Encourage an individualized physical activity plan and better carbohydrate counting. D. Recommend immediate insulin pump therapy to improve glucose control. Correct answer: C. Encourage an individualized physical activity plan and better carbohydrate counting. Explanation: Mrs. Lopez's ongoing high HbAC despite adherence to medication and diet suggests that lifestyle factors, particularly physical activity and carbohydrate intake, may be contributing to suboptimal blood glucose control. The most effective strategy in this case is to adjust her lifestyle factors rather than immediately change her medication regimen. Option could adjust her medication regimen to include additional oral agents. While adjusting medication may be necessary later, it is essential first to address lifestyle modifications, particularly physical activity and carbohydrate intake, which could significantly improve glucose control. Option B, emphasize more frequent blood glucose monitoring and insulin therapy. While increased monitoring and insulin therapy may help, the primary concern here seems to be Mrs. Lopez's lifestyle choices, and these need to be addressed first. Option D, recommend immediate insulin pump therapy to improve glucose control. An insulin pump could be considered for patients with difficulty managing their diabetes with injectable insulin. However, given Mrs. Lopez's issues are primarily related to sedentary behavior and poor dietary choices, this should not be the first line of intervention. An individualized physical activity plan and guidance on better carbohydrate counting will be key elements of her care plan and improve glucose control over time. Question 3, scenario-based. Mr. Jackson, a 55-year-old man with type 2 diabetes, has recently been diagnosed with hypertension and elevated cholesterol levels. His diabetes is currently managed with metformin and his HbAC is well controlled at 7%. However, his blood pressure remains high and his lipid levels are also above target. Considering the situation, which of the following actions would be most appropriate? Manage Mr. Jackson's overall health and reduce the risk of cardiovascular complications. A. Increase the dosage of metformin to improve glucose control. B. Introduce medications targeting both his blood pressure and cholesterol levels. C. Discontinue metformin and start insulin therapy to achieve better glucose control. D. Focus on dietary changes alone and monitor his condition without adding medications. Answer: B. Introduce medications targeting both his blood pressure and cholesterol levels. Explanation: Mr. Jackson's hypertension and elevated cholesterol, combined with his type 2 diabetes, significantly increases risk of cardiovascular diseases such as heart disease and stroke. In this scenario, the most appropriate action is to address these comorbidities with appropriate medications in addition to managing his diabetes. Options will increase the dosage of metformin. While metformin is effective for glucose control, increasing the dose will not address Mr. Jackson's hypertension or elevated cholesterol, which are major contributors to his cardiovascular risk. Option C. Discontinue metformin and start insulin therapy. There is no indication that Mr. Jackson's diabetes is not adequately controlled with metformin. His HbAC is 7%. Insulin therapy is not warranted unless his diabetes becomes more difficult to control. The priority here is managing his hypertension and lipid levels. Option D. Focus on dietary changes alone. While diet is important, his elevated blood pressure and cholesterol levels require pharmacological intervention for better control and to reduce the risk of cardiovascular complications. Appropriate medications for hypertension, such as ACE inhibitors or calcium channel blockers and cholesterol statins, are essential for comprehensive management and improving long-term outcomes for Jackson. Question 4. Which of the following is the most appropriate initial approach when addressing the nutritional needs of a diabetic patient who is newly diagnosed and exhibits obesity with insulin resistance? A. Encourage a low-calorie diet with high carbohydrates to increase insulin sensitivity. B. Recommend bariatric surgery as the first step in treatment. C. Emphasize a balanced diet with a focus on reducing caloric intake and improving insulin sensitivity. D. Recommend a high-protein, low-carbohydrate diet without monitoring blood glucose levels. Answer C. Emphasize a balanced diet with a focus on reducing caloric intake and improving insulin sensitivity. Explanation. For a diabetic patient with obesity and insulin resistance, the primary goal is to improve insulin sensitivity through dietary modifications. A balanced diet, focusing on reducing caloric intake while maintaining adequate nutrition, is critical for weight loss, improving insulin sensitivity, and achieving glycemic control. Optional. Encourage a low-calorie diet with high carbohydrates. High carbohydrate intake, even in a low-calorie diet, can worsen insulin resistance and raise blood glucose levels. Option B. Recommend bariatric surgery as the first step. Bariatric surgery is a consideration in patients with severe obesity and type 2 diabetes, but it is typically not the first step in treatment. Lifestyle modifications should be explored first. Option D. Recommend a high-protein, low-carbohydrate diet without monitoring blood glucose levels. Although a low-carb diet can be helpful for some patients, this approach might be too restrictive without a proper balance of macronutrients and should involve careful monitoring of glucose levels to avoid other risks. Question 5. Which of the following is the primary benefit of utilizing continuous glucose monitoring (CGM) systems in diabetes management? A. CGMs can replace the need for regular insulin injections. B. CGMs provide real-time glucose levels and trends for better management decisions. C. CGMs completely eliminate the risk of hypoglycemia. D. CGMs are most beneficial only for patients who are using insulin pumps. Answer. B. CGMs provide real-time glucose levels and trends for better management decisions. Explanation. Continuous glucose monitoring (CGM) systems are used to monitor blood glucose levels continuously, providing real-time data and trends. This allows for better decision-making in terms of insulin adjustments, meal planning, and physical activity. It provides more detailed insights into glucose fluctuations compared to self-monitoring of blood glucose (SEG). Often EGMs can replace the need for regular insulin injections. EMS do not replace insulin therapy. They are used to monitor glucose levels, but do not provide insulin delivery or replace injections. Option C. CGMs completely eliminate the risk of hypoglycemia. CGMs can help identify trends that may indicate hypoglycemia. They do not completely eliminate the risk of hypoglycemia, especially in patients who are on insulin therapy. Often CGMs are most beneficial only for patients who are using insulin pumps. CGMs can be beneficial for any patient with diabetes, not just those using insulin pumps. They are helpful in managing both type 1 and type 2 diabetes. Question 6, scenario-based. Mr. Harris, a 60-year-old male with type 2 diabetes, reports frequent episodes of dizziness, shakiness, and sweating, especially in the mornings. His blood glucose levels at these times are consistently below 7 mg. After reviewing his medication regimen, it appears that his morning dose of sulfonylureas might be contributing to these symptoms. Considering the situation, what would be the most appropriate next step in managing Mr. Harris's hypoglycemia? A. Increases dose of sulfonylurea to improve glucose control. B. Add an additional medication to address postprandial hypoglycemia. C. Adjust the timing or dosage of his sulfonylurea medication to reduce the risk of hypoglycemia. D. Switch him to an insulin regimen for better blood sugar control. Answer. C. Adjust the timing or dosage of his sulfonylurea medication to reduce the risk of hypoglycemia. Explanation. Sulfonylureas are oral medications that increase insulin secretion from the pancreas, but they can also lead to hypoglycemia, especially when the timing or dose is not adjusted for the patient's eating patterns. In Mr. Harris's case, his hypoglycemia symptoms in the morning suggest that his sulfonylurea dosage ought I need adjustment to prevent low blood glucose during the early hours. Option increases dose of sulfonylurea. Increasing the dose of sulfonylureas could worsen hypoglycemia, which is already a problem for Mr. Harris. This is not an appropriate action. Option B. Add an additional medication to address postprandial hypoglycemia. This might be helpful if his postprandial glucose levels were high, but his primary issue is morning hypoglycemia, not postprandial hypoglycemia. Option D. Switch him to an insulin regimen. Insulin could be an option, but switching to insulin therapy when the issue seems related to sulfonylurea dosage and timing would be premature. Adjusting the current therapy is more appropriate initially. Question 7. What is the primary advantage of using a goal-setting approach like SMART? Specific, measurable, achievable, relevant, time-bound goals in diabetes education. A. Ensures that patients can fully control their blood glucose levels without medical intervention. B. It helps create clear and individualized objectives that are realistic and motivating for the patient. C. It eliminates the need for ongoing monitoring of blood glucose. D. It allows for rapid changes in treatment regimens without follow-up assessments. Answer. B. It helps create clear and individualized objectives that are realistic and motivating for the patient. Explanation. The SMART goal-setting framework is designed to create clear, achievable, and individualized goals that enhance patient engagement and motivation. This approach is particularly useful in diabetes education because it helps patients set realistic and specific targets for blood glucose management, weight control, other lifestyle modifications, all of which are essential in diabetes care. It ensures that patients can fully control their blood glucose levels without medical intervention. While SMART goals can assist in managing diabetes, they do not eliminate the need for medical intervention. Effective diabetes management still requires monitoring and appropriate treatment. Option C. It eliminates the need for ongoing monitoring of blood glucose. SMART goals are meant to support and guide patients, but they do not replace the need for consistent monitoring of blood glucose. Option D. It allows for rapid changes in treatment regimens without follow-up assessments. SMART goals focus on long-term, realistic changes. They encourage ongoing assessment and follow-up, not hasty or unmonitored changes in treatment. Question 8. Which of the following lifestyle interventions is most likely to improve insulin sensitivity and help reduce blood glucose levels in a patient with type 2 diabetes? A. Increased protein intake to reduce overall calorie consumption. B. Moderate aerobic exercise for 30 minutes most days of the week. C. Elimination of all carbohydrates from the diet. D. Avoidance of physical activity due to risk of injury. Answer. B. Moderate aerobic exercise for 30 minutes most days of the week. Explanation. Moderate aerobic exercise, such as brisk walking, cycling, or swimming, can significantly improve insulin sensitivity and help reduce blood glucose levels. Regular physical activity enhances the body's ability to use insulin efficiently, lowering blood glucose levels and reducing the risk of cardiovascular complications in diabetes. Optional increased protein intake to reduce overall calorie consumption. While protein is important for nutrition, simply increasing protein intake without addressing overall caloric balance and incorporating exercise may not effectively improve insulin sensitivity. Option C. Elimination of all carbohydrates from the diet. Carbohydrates are a necessary part of a balanced diet, even for diabetic patients. The goal is to manage carbohydrate intake rather than eliminate it entirely. Option D, avoidance of physical activity due to risk of injury. Avoiding physical activity increases the risk of insulin resistance and worsens blood glucose control. Appropriate physical activity should be tailored to the patient's ability and condition, not avoided entirely. Question 9. Which of the following statements is true regarding the use of ALT inhibitors in type 2 diabetes management? ALT inhibitors are only effective for blood glucose control in patients who are not obese. BLT inhibitors work by increasing the renal excretion of glucose, thus lowering blood sugar. CLT inhibitors increase the risk of hypoglycemia in patients who are not on insulin therapy. DLT inhibitors are contraindicated in patients with a history of cardiovascular disease. Answer: BLT inhibitors work by increasing the renal excretion of glucose, thus lowering blood sugar. Explanation: ALT inhibitors are a class of oral medications used to manage type 2 diabetes. They work by inhibiting the sodium glucose cotransporter 2 ALT in the kidneys, which increases the renal excretion of glucose, thereby lowering blood sugar levels. These medications can also have additional benefits, such as weight loss, lowering blood pressure. Option E, ALT inhibitors are only effective for blood glucose control in patients who are not obese. ALT inhibitors can be effective in both obese and non-obese patients. Their effectiveness is not limited by obesity. Option C, ALT inhibitors increase the risk of hypoglycemia in patients who are not on insulin therapy. ALT inhibitors have a low risk of causing hypoglycemia on their own, as they do not stimulate insulin release. Hypoglycemia is more likely when used in combination with insulin or insulin secretagogues. Option D, ALT inhibitors are contraindicated in patients with a history of cardiovascular disease. ALT inhibitors have actually shown cardiovascular benefits and are often used in patients with type 2 diabetes and a history of cardiovascular disease to reduce the risk of heart failure and stroke. Question 10. Which of the following is an appropriate recommendation for a patient with type 1 diabetes who is planning to increase their exercise regimen? A. Decrease insulin doses to prevent hypoglycemia. B. Increase carbohydrate intake before and during exercise to prevent hypoglycemia. C. Exercise immediately after meals for optimal blood glucose control. D. Limit exercise intensity to avoid affecting blood glucose levels. Answer: B. Increase carbohydrate intake before and during exercise to prevent hypoglycemia. Explanation: for patients with type 1 diabetes, exercise can lead to a drop in blood glucose levels, potentially causing hypoglycemia. To prevent this, it is recommended that patients increase their carbohydrate intake before and during exercise. This helps to maintain stable blood glucose levels during physical activity. Optionals decrease insulin doses to prevent hypoglycemia. Reducing insulin doses may lead to elevated blood glucose levels post-exercise, which is not advisable. Option C, exercise immediately after meals for optimal blood glucose control. Exercising immediately after meals could cause a spike in blood glucose levels. It's often recommended to wait while after meals, depending on the timing and type of exercise. Option D, limit exercise intensity to avoid affecting blood glucose levels. While exercise intensity should be tailored to individual fitness levels, completely limiting exercise intensity is not necessary. Moderate intensity exercise is generally beneficial for glucose control, and the key to avoiding issues like hypoglycemia is ensuring proper carb intake and glucose monitoring. These questions are designed to challenge your understanding of diabetes management, providing you with deeper grasp of how treatment strategies and lifestyle interventions can impact glucose control and overall health in patients with diabetes. If you need further clarification or additional questions, feel free to ask. Question 11. Sarah, a 54-year-old woman with type 2 diabetes, reports that she has been feeling fatigued, increasingly thirsty, and has been urinating more frequently than usual. She admits that her blood glucose levels have been difficult to control despite following her prescribed oral medications. Her latest HbAC is 9.2%. What should Sarah's diabetes educator recommend as the next step in her care plan? A. Increase the dose of her current oral medications. B. Consider adding insulin therapy or another injectable medication. C. Suggest bariatric surgery as a treatment option. D. Increase physical activity and focus on weight loss strategies. Answer: B. Consider adding insulin therapy or another injectable medication. Explanation. Given Sarah's symptoms, fatigue, increased thirst, frequent urination, and her high HbAC of 9.2%, her diabetes is not well controlled with oral medications alone. The next logical step would be to intensify her therapy, which may involve adding insulin or other injectable medications like GLP-1 receptor agonists. While BOS and exercise are important components of management, the elevated HbAC indicates that her current treatment plan is insufficient, necessitating a more aggressive approach. OPSI will increase the dose of her current oral medications. While increasing medication doses could be considered, the fact that Sarah's diabetes is not controlled with oral medications suggests that other strategies, such as adding insulin, may be more effective. Option C suggests bariatric surgery is a treatment option. While bariatric surgery may benefit some patients with type 2 diabetes, it is not typically considered first line for a patient like Sarah who is primarily facing issues with medication adherence or effectiveness. Option D, increase physical activity and focus on weight loss strategies. These are important lifestyle factors, but Sarah's primary issue appears to be poor glucose control, indicating the need for adjustments in her pharmacological treatment rather than just lifestyle changes. Question 12. A 70-year-old patient with type 2 diabetes and hypertension presents with symptoms of neuropathy, including tingling and numbness in the feet. The patient also reports a recent decline in vision. The healthcare provider orders a comprehensive diabetes assessment. Which of the following should be included in the evaluation to assess the patient's complications? A. Blood pressure measurement. B. Fundoscopic eye exam. C. Urine protein screening. D. All of the above. Answer. D. All of the above. Explanation. This patient is exhibiting symptoms that suggest multiple diabetes-related complications, including neuropathy and possible diabetic retinopathy. Therefore, a comprehensive evaluation should include blood pressure measurement. Option A. Hypertension is common in patients with diabetes and can exacerbate complications like diabetic nephropathy and retinopathy. Monitoring blood pressure is a critical part for managing diabetic complications. Fundoscopic eye exam. Option B. Diabetic retinopathy is a leading cause of blindness in diabetic patients. A fundoscopic exam is necessary to evaluate the retina for signs of damage. Urine protein screening. Option C. Proteinuria is an early sign of diabetic nephropathy, which is common in long-term diabetes. Screening for protein in the urine is essential in assessing kidney function. All of these components are necessary for a thorough assessment of the patient's diabetic complications. Question 13. You are working with a 45-year-old man with type 2 diabetes who is interested in starting an exercise program. He has been sedentary for several years and reports occasional joint pain. After educating him on the benefits of physical activity for glucose control, you suggest he start with low-impact exercises. What is the most important consideration in developing an exercise plan for this patient? A. Ensure that the patient has adequate blood glucose control before starting exercise. B. Focus on strength training to increase muscle mass. C. Advise the patient to avoid any exercise that causes joint pain. D. Develop a gradual progressive exercise plan with a focus on aerobic activity. Answer D. Develop a gradual progressive exercise plan with a focus on aerobic activity. Explanation. For a sedentary patient with type 2 diabetes, starting with low-impact aerobic activities like walking, swimming, or cycling is a key recommendation. These types of exercises improve insulin sensitivity and glucose control without putting excessive strain on the joints, which is important for a patient with reported joint pain. OPSI will ensure that the patient has adequate blood glucose control before starting exercise. While monitoring blood glucose is important, it is not the most critical factor in starting exercise. Exercise itself is a beneficial strategy for improving blood glucose levels. Option B. Focus on strength training to increase muscle mass. Strength training is beneficial for glucose control, but for a sedentary patient, the primary focus should initially be on aerobic activity to improve cardiovascular fitness and overall mobility. Option C. Advise the patient to avoid any exercise that causes joint pain. While joint pain should be monitored, avoiding all exercise because of joint discomfort is not the best approach. Instead, low-impact activities that do not exacerbate pain should be emphasized. Question 14. A 33-year-old woman with gestational diabetes presents for A follow-up appointment after delivering a healthy baby. She is concerned about her future risk of developing type 2 diabetes. What is the most appropriate recommendation for this patient regarding follow-up care? A. Repeat screening for type 2 diabetes within 1 year of delivery. B. Begin treatment with metformin to prevent future diabetes. C. Continue monitoring glucose levels indefinitely. D. No follow-up is necessary if blood glucose returns to normal after delivery. Answer A. Repeat screening for type 2 diabetes within 1 year of delivery. Explanation: women who have a gestational diabetes are increased risk for developing type 2 diabetes later in life. It is recommended that these women be screened for type 2 diabetes 2 weeks after delivery and then annually thereafter as part of ongoing monitoring and prevention. Option B. Begin treatment with metformin to prevent future diabetes. While metformin may be used in some high-risk patients, it is not universally recommended as a preventative treatment for all women with a history of gestational diabetes. Option C. Continue monitoring glucose levels indefinitely. Regular follow-up is important, but indefinite glucose monitoring is not necessary if the patient has no signs of diabetes or prediabetes and normal glucose levels post-delivery. Option D. No follow-up is necessary if blood glucose returns to normal after delivery. This is incorrect. Despite normal glucose levels post-delivery, the risk of type 2 diabetes remains elevated, making follow-up screening essential. Question 15. A 60-year-old male patient with type 2 diabetes and at ER of 31 is considering weight loss surgery. He has not been successful in losing weight through diet and exercise alone. His HbAC is 8.5% and his diabetes is inadequately controlled. What should the diabetes educator consider when discussing bariatric surgery with this patient? A. Bariatric surgery is an effective option for patients with type 2 diabetes and obesity, but it is not recommended if HbAC is above 7%. B. Bariatric surgery can lead to significant weight loss and improvement in blood glucose control, but it should be considered after lifestyle interventions have failed. C. The patient should not be considered for bariatric surgery unless he is younger than 50 years old. D. Bariatric surgery can cure diabetes completely, and the patient can stop all diabetes medications after surgery. Answer: B. Bariatric surgery can lead to significant weight loss and improvement in blood glucose control, but it should be considered after lifestyle interventions have failed. Explanation: bariatric surgery has been shown to be an effective treatment option for patients with type 2 diabetes and obesity, particularly when lifestyle changes, diet, and exercise have not been successful. Surgery can lead to significant weight loss and in many substantial improvement in blood glucose control, but it is typically recommended after more conservative methods have been exhausted. Option: bariatric surgery is not recommended if HbAC is above 7%. There is no strict HbAC cutoff for considering bariatric surgery. The decision is based on the failure of lifestyle modifications and the overall health risks associated with obesity and diabetes. Option C. The patient should not be considered for bariatric surgery unless he is younger than 50 years old. There is no age restriction for bariatric surgery in patients with type 2 diabetes, though older patients may have additional considerations related to surgery and recovery. Option D. Bariatric surgery can cure diabetes completely. While bariatric surgery can improve or even normalize blood glucose levels, it is not a cure for diabetes. Ongoing management, including monitoring and sometimes medication, is still necessary. Question 16. A 55-year-old woman with type 2 diabetes has been prescribed an ALT inhibitor for the management of her blood glucose levels. During a follow-up visit, she reports feeling lightheaded and has had increased urination. Her blood pressure has also dropped from 140/85 mmHg to 110/70 What is the most likely explanation for these symptoms? A. The SLT inhibitor is causing a drop in blood glucose levels, leading to hypoglycemia. B. SLT inhibitor is causing increased fluid loss, leading to dehydration and hypotension. C. The SLT inhibitor is causing renal impairment, which has led to reduced blood pressure. D. The patient's symptoms are unrelated to the medication and may be due to another cause, such as an infection. Answer: B. The SLT inhibitor is causing increased fluid loss, leading to dehydration and hypotension. Explanation: SLT inhibitors work by preventing glucose reabsorption in the kidneys, leading to increased urinary glucose and fluid loss. This can cause dehydration, which in turn may lead to a drop in blood pressure and lightheadedness. It is important to monitor for these side effects, especially in patients who may be at risk for depletion. Option because SLT inhibitor is causing a drop in blood glucose levels, leading to hypoglycemia. SLT inhibitors generally do not cause hypoglycemia on their own unless combined with other medications that can lower blood sugar like insulin or sulfonylureas. Option C, SLT inhibitor is causing renal impairment, which has led to reduced blood pressure. While renal function should be monitored in patients take SLT inhibitors, this is not the primary cause of the symptoms described. Option D, the patient's symptoms are unrelated to the medication and may be due to another cause, such as an infection. The patient's symptoms are more likely related to the medication than to another cause like infection, though thorough evaluation is necessary. Question 17. A 45-year-old patient with type 1 diabetes asks about the use of continuous glucose monitoring (CGM). Which of the following is an appropriate response regarding the benefits of CGM in type 1 diabetes management? A CGM is primarily used to eliminate the need for fingerstick blood glucose monitoring entirely. BCGM can help provide real-time data for better glucose control and reduce the frequency of severe hypoglycemic episodes. CCGM is only useful for patients who are not achieving optimal glucose control with insulin therapy. DCGM is recommended for all patients with type 1 diabetes, regardless their level of control or treatment approach. Answer: BCGM can help provide real-time data for better glucose control and reduce the frequency of severe hypoglycemic episodes. Explanation: continuous glucose monitoring (CGM) provides real-time glucose data, allowing patients with type 1 diabetes to make immediate adjustments to their insulin therapy. CGM can also help reduce the frequency of severe hypoglycemic episodes by providing alerts for low, high glucose levels. However, it is not typically used to completely replace fingerstick monitoring, and its primary benefit is in enhancing glucose control. Open EGM is primarily used to eliminate the need for fingerstick blood glucose monitoring entirely. CCGM can reduce the need for fingersticks, but it is not meant to eliminate them entirely. Patients may still need to perform fingersticks to confirm readings or calibrate the device. Option C, CGM is only useful for patients who are not achieving optimal glucose control with insulin therapy. ECGM can benefit all patients with type 1 diabetes, not just those struggling with glucose control. Option D, CGM is recommended for all patients with type 1 diabetes, regardless of their level of control or treatment approach. A CGM is not necessarily recommended for all patients. It is more commonly used for those who require intensive glucose monitoring, such as those with frequent hypoglycemia or those on insulin pumps. Question 18. A 72-year-old male patient with type 2 diabetes is prescribed a HIAN receptor agonist to improve his blood glucose control. He reports feeling full quickly when eating and has lost a few pounds over the past few weeks. What is the most likely mechanism for these changes? A. GLP-1 receptor agonists stimulate insulin secretion and delay gastric emptying, leading to reduced appetite and weight loss. B. GLP-1 receptor agonists increase the body's sensitivity to insulin and suppress the appetite through central nervous system pathways. C. GLP-1 receptor agonists increase the renal excretion of glucose, leading to weight loss. D. GLP-1 receptor agonists increase the breakdown of fat, adipose tissue, directly causing weight loss. Answer: A. GLP-1 receptor agonists stimulate insulin secretion and delay gastric emptying, leading to reduced appetite and weight loss. Explanation: GLP-1 receptor agonists work by stimulating insulin secretion in response to meals and by delaying gastric emptying, which results in reduced appetite and weight loss. These effects are especially helpful for patients with type 2 diabetes who need to improve both blood glucose control and weight management. Option B, GLP-1 receptor agonists increase the body's sensitivity to insulin and suppress the appetite through central nervous system pathways. Why GLP-1 receptor agonists can have an effect on insulin sensitivity. Their primary mechanisms of action are related to insulin secretion and delayed gastric emptying. Option C, GLP-1 receptor agonists increase the renal excretion of glucose, leading to weight loss. This describes the mechanism of action of EDLT inhibitors, GLP-1 receptor agonists. Option D, GLP-1 receptor agonists increase the breakdown of fat in adipose tissue, directly causing weight loss. GLP-1 receptor agonists do not directly increase fat breakdown. Their weight loss effects are primarily due to appetite suppression and delayed gastric emptying. Question 19. A 50-year-old woman with type 2 diabetes is starting insulin therapy. She is concerned about the risk of hypoglycemia. Which of the following statements best addresses her concern? A. Insulin therapy will cause hypoglycemia in all patients, so it's best to avoid insulin unless absolutely necessary. B. Hypoglycemia can occur, especially with certain types of insulin, but it can often be prevented with proper monitoring and adjustment of the dose. C. Insulin therapy is safe and does not cause hypoglycemia as insulin doses are carefully controlled by the healthcare provider. D. If hypoglycemia occurs, it is always to an insulin overdose, which can be prevented by strict adherence to diet and exercise. Answer B. Hypoglycemia can occur, especially with certain types of insulin, but it can often be prevented with proper monitoring and adjustment of the dose. Explanation. Hypoglycemia is a potential risk of insulin therapy, particularly with certain types of insulin like rapid-acting or long-acting. However, with careful monitoring, dose adjustments, and appropriate education, hypoglycemia can often be prevented. Patients should be educated about recognizing symptoms of hypoglycemia and how to treat it promptly. Optional insulin therapy will cause hypoglycemia in all patients, so it's best to avoid insulin unless absolutely necessary. While hypoglycemia's potential risk is not inevitable, and insulin therapy is essential for many patients to achieve good glucose control, the goal is to balance the dose to minimize risks. Option C, insulin therapy is safe and does not cause hypoglycemia. Insulin therapy can cause hypoglycemia, especially if the dose is too high or the timing of meals and insulin is not properly managed. Option D, if hypoglycemia occurs, it is always due to an insulin overdose. Hypoglycemia can result from several factors, including inadequate food intake, exercise, or mistimed insulin doses, not just an insulin overdose. Question 20. A 60-year-old male with type 2 diabetes is concerned about his kidney health. He has a history of hypertension and is currently taking an ACE inhibitor. His urine albumin to creatinine ratio is found to be elevated. What is the most appropriate next step in managing his diabetes-related kidney disease? A. Increase the dose of the ACE inhibitor to target a higher level of blood pressure control. B. Start treatment with an ALT inhibitor, as these medications have been shown to reduce kidney-related complications in diabetes. C. Discontinue the ACE inhibitor as it is causing renal impairment. D. Refer the patient for immediate dialysis as kidney function is already compromised. Answer. B. Start treatment with an ALT inhibitor, as these medications have been shown to reduce kidney-related complications in diabetes. Explanation. ALT inhibitors have been shown to reduce kidney-related complications in patients with type 2 diabetes and are recommended for patients with elevated albuminuria, as in this case. ACE inhibitors are also important in managing kidney health in diabetes, but the addition of an ALT inhibitor would be appropriate to further protect kidney function. Option was increase the dose of the ACE inhibitor. While ACE inhibitors are important for managing blood pressure and kidney function in diabetes, adding an ALT inhibitor would provide additional benefits. Option C. Discontinue the ACE inhibitor. ACE inhibitors are beneficial for kidney protection in diabetic patients, and there is no indication to discontinue it unless there is a clear adverse effect. Option D. Refer the patient for immediate dialysis. Dialysis is not indicated at this stage based solely on elevated albumin to creatinine ratio. The patient is likely still in the early stages of kidney disease and should be managed with medication. Question 21. A 60-year-old male patient with type 2 diabetes has been prescribed a sulfonylurea glimepiride for blood glucose control. He reports having hypoglycemic episodes during the night, especially if he skips dinner. What would be the most appropriate recommendation for preventing these episodes? A. Increase the glimepiride dose to ensure better blood glucose control. B. Encourage the patient to avoid skipping meals, particularly the evening meal, to prevent hypoglycemia. C. Switch the patient to a rapid-acting insulin regimen to improve control and prevent nighttime hypoglycemia. D. Discontinue the glimepiride and initiate metformin to reduce the risk of hypoglycemia. Answer. B. Encourage the patient to avoid skipping meals, particularly the evening meal, to prevent hypoglycemia. Explanation. Sulfonylureas like glimepiride stimulate insulin secretion, which can lead to hypoglycemia, especially if meals are skipped. The most effective way to prevent Nocturnal hypoglycemia is to ensure that the patient consistently consumes meals, particularly in the evening, as this helps balance insulin release. Option was increase the glimepiride dose. Increasing the dose could increase the risk of hypoglycemia, especially if the patient skips meals. This would not be advisable. Option C, switch the patient to a rapid-acting insulin regimen. Rapid-acting insulin would also carry a risk of hypoglycemia if meal timing is not consistent, and it would be more complex than adjusting meal habits. Option D, discontinue the glimepiride and initiate metformin. While metformin is an effective treatment for type 2 diabetes, sulfonylureas are still commonly used. Simply discontinuing glimepiride may not be necessary, especially if meal habits are adjusted. Question 22. A 70-year-old woman with type 2 diabetes, hypertension, and hyperlipidemia is currently on a regimen that includes metformin, a statin, and an ACE inhibitor. Her latest blood work shows a serum creatinine of 1.9 mdl, which is above her baseline of 1.3 mdl. What is the most appropriate next step in managing this patient? A. Discontinue the metformin and monitor kidney function closely. B. Increase the dose of the ACE inhibitor to improve kidney function. C. Switch the patient from the ACE inhibitor to an angiotensin receptor blocker, ARB. D. Continue current medications as prescribed without any changes. Answer A. Discontinue the metformin and monitor kidney function closely. Explanation. Metformin should be discontinued in patients with significant renal impairment, e.g., serum creatinine 1.5 mdl in women, due to the increased risk of lactic acidosis. The patient's elevated serum creatinine indicates a decline in kidney function, and metformin can be contraindicated in such cases. Close monitoring and alternate diabetes treatments such as insulin LT inhibitors may be needed. Option B. Increase the dose of the ACE inhibitor. ACE inhibitors are beneficial for kidney protection, but increasing the dose in the context of worsening renal function may not be appropriate without further evaluation. Option C. Switch the patient from the ACE inhibitor to an angiotensin receptor blocker. ARBs may be considered as alternatives to ACE inhibitors for kidney protection, but there is no indication that switching is required at this point based on the information provided. Option D. Continue current medications as prescribed without any changes. Continuing metformin despite impaired kidney function could increase the risk of lactic acidosis and should be avoided. Question 23. A 40-year-old man with type 2 diabetes has been experiencing frequent urination and increased thirst over the past month. His blood glucose levels have been consistently above 300 mdl despite adherence to his medication regimen. Urine ketones are negative. Which of the following is the most appropriate next step in management? A. Increase the dose of his insulin therapy to improve glucose control. B. Start a sodium glucose cotransporter 2-ADLT inhibitor to improve glucose control and reduce symptoms. C. Initiate a basal insulin regimen to better control his blood glucose. D. Investigate for other causes of hypoglycemia, such as infection, and consider altering his medication regimen. Answer. D. Investigate for other causes of hypoglycemia, such as infection, and consider altering his medication regimen. Explanation. Persistent hypoglycemia above 300 mdl despite medication adherence suggests that the patient's diabetes is not adequately controlled and other potential causes should be investigated. The absence of urine ketones makes diabetic ketoacidosis (DKA) less likely, but infections or underlying conditions, e.g., stress or non-adherence, may be contributing to the elevated glucose. A thorough evaluation and potentially altering the medication regimen are necessary. Option will increase the dose of his insulin therapy. Increasing insulin doses might be warranted if the patient's blood glucose continues to be high after further evaluation, but root cause should first be identified. Option B. Start sodium glucose cotransporter 2-ADLT inhibitor. An ALT inhibitor may help reduce blood glucose, but it would not address the root cause of the patient's high blood glucose levels at this time. Option C. Initiate basal insulin regimen. If the patient is already on insulin, adding basal insulin may not address the underlying cause of hypoglycemia. Question 24. A 45-year-old woman with type 2 diabetes and a history of retinopathy presents for a routine eye exam. The ophthalmologist notes worsening diabetic retinopathy, and the patient is concerned about losing her vision. What is the most important aspect of managing diabetic retinopathy in this patient? A. Tight control of blood glucose to prevent further progression of retinopathy. B. Referral for laser surgery to treat the retinopathy immediately. C. Initiation of an antihypertensive medication to prevent damage to the retina. D. Regular eye exams to monitor for changes and further complications. Answer A. Tight control of blood glucose to prevent further progression of retinopathy. Explanation. Tight glucose control is the most important intervention for preventing the progression of diabetic retinopathy. Studies have shown that good blood glucose management reduces the risk of worsening retinopathy and vision loss. Option B. Referral for laser surgery. Laser surgery may be indicated in more advanced stages of diabetic retinopathy, but good blood glucose control is the first step in managing the condition. Option C. Initiation of an antihypertensive medication. While controlling blood pressure is important in preventing complications of diabetes, it is not as directly relevant to retinopathy as glucose control. Option D. Regular eye exams. Regular eye exams are crucial for monitoring the progression of retinopathy, but managing blood glucose is the most important intervention. Question 25. A 60-year-old male patient with type 2 diabetes and cardiovascular disease is prescribed iron receptor agonist. He is concerned about potential gastrointestinal side effects, such as nausea and vomiting. What is the most appropriate counseling regarding these potential side effects? A. The gastrointestinal side effects are typically severe and require discontinuing the medication immediately. B. Nausea and vomiting are common at the initiation of therapy but tend to subside over time as the body adjusts to the medication. C. If nausea occurs, it should be treated with an antiemetic drug to prevent vomiting. D. The medication should be discontinued if any gastrointestinal side effects occur, as they may be a sign of more complications. Answer. B. Nausea and vomiting are common at the initiation of therapy but tend to subside over time as the body adjusts to the medication. Explanation. Gastrointestinal side effects, including nausea, are common when starting GLP-1 receptor agonists, but these effects often decrease after a few days or weeks as the body adjusts to the medication. Patients should be counseled to continue therapy if these side effects are mild and temporary. Option quiz. The gastrointestinal side effects are typically severe and require discontinuing the medication immediately. While some patients may experience severe side effects, most side effects are mild and transient. Discontinuing the medication is generally unnecessary unless symptoms persist or worsen. Option C. If nausea occurs, it should be treated with an antiemetic drug to prevent vomiting. Antiemetic medications are generally not necessary unless the nausea is particularly severe. Supportive measures like eating smaller meals may be more effective. Option D. The medication should be discontinued if any gastrointestinal side effects occur, as they may be a sign of more serious complications. Discontinuing the medication is typically not required unless symptoms are severe or persistent. Most gastrointestinal side effects are self-limited. Question 26. A 55-year-old woman with type 2 diabetes and a 35 kilograms has been trying to lose weight without much success. Her AC is 7.8% and her blood pressure is 145/9 mmHg. Which of the following would be the most appropriate intervention to improve both her diabetes control and weight management? A. Initiate GLP-1 receptor agonist to help with weight loss and improve blood sugar control. B. Recommend low carbohydrate diet without making any medication changes. C. Start insulin therapy to better control her blood glucose. D. Prescribe diuretic to help manage her blood pressure and reduce her weight. Answer A. Initiator, the iron receptor agonist to help with weight loss and improve blood sugar control. Explanation. GLP-1 receptor agonists not only help improve blood glucose control, but also promote weight loss, which is beneficial for patients with type 2 diabetes and obesity. These medications also have cardiovascular benefits and may help lower blood pressure. Option B. Recommend a low carbohydrate diet. While dietary changes are important, pharmacologic intervention with GLP-1 agonists can provide a more effective and immediate impact on both weight and glucose control. Option C. Start insulin therapy. Insulin therapy can be used in type 2 diabetes, but it may lead to weight gain. In this case, other medications such as GLP-1 agonists would be more appropriate to address both weight and glucose control. Option D. Prescribe a diuretic. Diuretics can lower blood pressure but would not address the patient's weight or blood glucose control directly. Question 27. A 50-year-old male with type 2 diabetes and diabetic nephropathy present with persistent albuminuria. His blood pressure is 140/80 Fg. Which of the following interventions would be most beneficial in reducing the progression of kidney disease in this patient? A. Increases dose of metformin to better control his blood glucose. B. Start an angiotensin-converting enzyme ACE inhibitor to reduce proteinuria and protect kidney function. C. Initiate a sodium glucose cotransporter 2 ADLT inhibitor to improve kidney function. D. Recommend a low-protein diet to reduce kidney workload and preserve function. Answer. B. Start an angiotensin-converting enzyme ACE inhibitor to reduce proteinuria and protect kidney function. Explanation. ACE inhibitors are first-line therapy for patients with diabetic nephropathy and albuminuria, as they reduce proteinuria and help protect kidney function. They also lower blood pressure, which is critical in managing kidney disease. Obviously increases dose of metformin. While metformin helps control blood glucose, it does not address kidney protection. In fact, metformin should be used cautiously in patients with advanced kidney disease. Option C. Initiate an ALT inhibitor. ALT inhibitors have benefits in reducing kidney disease progression and cardiovascular risk. However, ACE inhibitors are typically used first for albuminuria and kidney protection in diabetic nephropathy. Option D. Recommend a low-protein diet. While dietary modifications can help manage kidney function, the first-line treatment for reducing proteinuria and preserving kidney function in diabetic nephropathy is an ACE inhibitor. Question 28. A 62-year-old man with type 2 diabetes, hypertension, and a history of myocardial infarction is prescribed empagliflozin, an ALT inhibitor, to help with glucose control. Which of the following is a known benefit of this medication for patients with type 2 diabetes and cardiovascular disease? A. It increases the risk of hypoglycemia. B. It reduces the risk of heart failure, hospitalization, and cardiovascular mortality. C. It improves blood glucose control without any effects on cardiovascular outcomes. D. It can increase the risk of diabetic ketoacidosis (DK). Answer. B. It reduces the risk of heart failure, hospitalization, and cardiovascular mortality. Explanation. ALT inhibitors like empagliflozin have been shown to provide cardiovascular benefits, including reducing the risk of heart failure, hospitalization, and cardiovascular mortality in patients with type 2 diabetes and cardiovascular disease. Options increases the risk of hypoglycemia. ALT inhibitors do not typically cause hypoglycemia on their own, although they can increase the risk if used with other glucose-lowering medications that cause hypoglycemia. Option C. It improves blood glucose control without any effects on cardiovascular outcomes. This is incorrect because ALT inhibitors have proven cardiovascular benefits in addition to improving blood glucose control. Option D. It can increase the risk of diabetic ketoacidosis (DKA). ALT inhibitors may increase the risk of EKA, particularly in patients with type 1 diabetes. This is a rare side effect in type 2 diabetes and not a primary concern with empagliflozin. Question 29. A 48-year-old female with type 2 diabetes presents with blurred vision and difficulty reading. Her most recent AC is 8.2% and she has had difficulty managing her blood sugar. Her ophthalmologist notes early signs of diabetic retinopathy. What should be the first step in managing this patient's condition? A. Initiate insulin therapy to improve blood glucose control. B. Start GLP-1 receptor agonist to improve glucose control and prevent further eye damage. C. Encourage stricter blood glucose control and blood pressure management to prevent further retinal damage. D. Refer her for laser surgery to prevent vision loss. Answer. C. Encourage stricter blood glucose control and blood pressure management to prevent further retinal damage. Explanation. Tight blood glucose control is essential to prevent the progression of diabetic retinopathy, as is managing blood pressure. Stricter control of these factors can reduce the risk of worsening retinopathy and preserve vision. Option was initiate insulin therapy. Insulin may be needed to improve blood glucose control, but the primary focus should be on overall management rather than an immediate insulin regimen. Option B. Start a GLP-1 receptor agonist. While GLP-1 receptor agonists can help with glucose control, the priority should be on improving overall management, including blood glucose and blood pressure control. Option D. Refer her for laser surgery. Laser surgery is typically reserved for more advanced stages of retinopathy and would not be indicated for early signs. Question 30. A 68-year-old woman with type 2 diabetes is taking insulin therapy and reports frequent episodes of hypoglycemia. Her AC is 6.5%. What would be the most appropriate recommendation to prevent further hypoglycemic episodes? A. Increase the frequency of her insulin doses to better control her blood glucose. B. Reduce the insulin dosage or adjust her regimen to prevent hypoglycemia. C. Initiate E1 receptor agonist to help with blood glucose control without hypoglycemia. D. Recommend a carbohydrate-rich diet to prevent blood glucose fluctuations. Answer: B. Reduce the insulin dosage or adjust her regimen to prevent hypoglycemia. Explanation: frequent hypoglycemic episodes in a patient with AAC of 6.5% suggest that the insulin dose may be too high. Reducing the insulin dosage or adjusting the insulin regimen, such as switching to a basal bolus approach, can help prevent hypoglycemia while still maintaining good glucose control. Option was increase the frequency of her insulin doses. Increasing insulin doses could increase the risk of hypoglycemia further and is not recommended. Option C. Initiate E1 receptor agonist. GLP-1 receptor agonists are beneficial for glucose control but do not directly address hypoglycemia risk from insulin therapy. Option D. Recommend a carbohydrate-rich diet. Although carbohydrate intake affects blood glucose, dietary changes alone are not sufficient to control frequent hypoglycemia caused by insulin overuse.